16 to 17 centimeters. This lady has now multiple vertebral fractures at thoracic and lumbar region. This is how people lose their height, and we see the kyphosis in the older ladies. We can close this. Okay, no more movie sessions. This is the reason why we need to treat osteoporosis. Everybody puts a lot of pressure on breast cancer, heart disease, and stroke, but look at the combination risk. The combination risk of osteoporosis fracture is way more than all three of them. This is according to the National Osteoporosis Guidelines. Now, who gets this? There are certain risk factors which are non-modifiable, that is age, race, female gender, early menopause, slender build, and positive family history. So we cannot change our families, but yes, we can take care of certain things like low calcium intake, low vitamin D, as Dr. Mehra said, hormone deficiency, sedentary lifestyle, cigarette cessation, which is, I've not had any slides, but smoking definitely has been associated with osteoporosis. Alcohol, more than 2 drinks, especially a day, caffeine, and some medications, including glucocorticoids, anticonvulsants, heparin, and we have to remember that thyroxine in excess, everybody is hypothyroid and we keep on giving replacing thyroid hormone. We have to make sure we do not give it to them in excess so that they don't get hypothyroid. As per classification, there are 2 kinds of osteoporosis. One is postmenopausal, that we all know about, and then age-related. This is what it shows here. As we are all growing older, by the time we are in 30s, our peak bone formation has occurred. We have attained a peak bone mass. And after that, you can see there is a slow deterioration, which is about 1 to 2% a year. And then after menopause and after about 60, there is a rapid decline in our peak bone mass. And by the time a lady reaches the age of 75 to 80 years, she has lost about 40% of the peak bone mass, which was achieved by age 30. Now, what is osteoporosis? This is a common question that, normal bone score is anything which is less than -1 is normal. We don't need to treat it unless somebody has already come with some fractures. Osteopenia, -1 to 2.5, and T-score of -2.5 is osteoporosis. And one thing to remember is anybody who's got even osteopenia but history of vertebral fracture is considered severe osteoporosis, and we need to treat that. Types of testing that needs to be done in our country, we have BMD is the most important thing that we need to do, and that's the only, I think, test available. I don't know if we have ultrasound, if anybody else can, but I think BMD is the gold standard here. We do have, okay. The National Osteoporosis Guidelines are who should get this BMD test. Postmenopausal women above the age of 65 with additional risk factors. Below the age of 65 with additional risk factors, which could be a family history of fracture, which could be a history of taking corticosteroid. So anybody who's below 65 but has additional risk factors needs to get a BMD. All the women above 65, there's no question about it, should be getting a BMD. And all the men. Somebody asked in audience, why is it always the she? But all the he's need to get it after 70 as well. Okay, this is a very interesting questionnaire that I wanted to let everybody in the audience know. It's called FRAX, WHO Fracture Risk Assessment Tool. It is available on internet. And if your patients cannot do the BMD because it's very expensive, you can just go on Google, print, and decrease the risk of fracture by about 25%. But again, then there are disadvantages to it, which is increased risk of thromboembolic disease. And now we are all worried about the cardiovascular and the stroke events after this women's health study. Roloxifene currently is the only SERM, but there are few SERMs coming out in the market. This is a MORE trial, which came out in 1999 in JAMA, and this showed that patients without a pre-existing vertebral fracture, it reduced the risk of vertebral fracture by about 55%, and patients with a pre-existing vertebral fracture, it reduced the risk by 30%. It has no data on the hip fracture. Now, available bisphosphonates, which is the most common form of therapy available worldwide. We have oral, which is alendronate, rezidronate, and ibendronate. And the IV is ibendronate, which is Bonviva in our country, and zoledronic acid. Off-label use, spermidronate has been used sometimes, but normally we don't use that. Alendronate, this is a study which FIT trial that already Dr. Humera has talked about. This is a FIT trial that came out in 1999 and it showed 59% risk reduction of vertebral fractures within the first year. And it also showed about 51% reduction in hip fracture within the first year and about wrist fracture, about 48% risk reduction in wrist fractures. This is an important study that came out in New England Journal of Medicine in 2004, and in this they have shown the 10-year data on patients with alendronate, and they showed a constant increase in BMD over a period of time. We always come across these patients who say that they've been taking Fosamax or any other medication for 4 years, 5 years. There is no fixed data. There is no fixed data to it, but generally what happens is we normally try to give it for 5 years and then we give it a break, but this data at least suggests that we can safely give it for 10 years. I've been just told I only have 5 more minutes, so we'll go faster. Rosidenate is, of course, what comes with the name of Actonel Word trial. It showed consistent decrease in vertebral fracture risk of 65% at year 1, which was consistent by 3 years. And this has been approved for risk reduction in both osteoporosis and glucocorticoid-induced osteoporosis. Arbentorate, which is called Bonviva,